Good afternoon, ladies and gentlemen, and welcome to the CHSRF On Call. I would like to remind you that this conference call is being recorded. At this time, all participants are in a listen-only mode. For those participants on the phone lines, if you require operator assistance at any time during the call, please press star then 0 on your touch-tone phones. For technical difficulties, please press the tech support button at the bottom of your screen. I would now like to turn the meeting over to Mr. Stephen Samis, Vice President, Programs at CHSRF. Please go ahead, Mr. Samis.
Thank you and welcome to CHSRF On Call, an interactive series by the Canadian Health Services Research Foundation. CHSRF On Call brings together policymakers, healthcare executives, researchers, the public, and you to be part of a dialogue about ways to improve healthcare for Canadians. As you heard, my name is Stephen Samis. I'm Vice President of Programs at CHSRF. Welcome to today's call, and today we're exploring key elements toward health system transformation. It's well known that money alone cannot improve healthcare. What we need are a coherent set of strategies to transform and improve our system to achieve better alignment between the care offered and the care that Canadians require. We're very pleased that joining us today to talk about the integrated vision and approach needed to support healthcare transformation are Dr. Ross Baker, a professor in the Department of Health Policy, Management, and Evaluation at the University of Toronto, where he teaches and carries out research on patient safety, quality improvement strategies, and leadership and organizational change. And we're also very pleased to have Kay Lewis, who is CEO of Stanton Territorial Health Authority in Yellowknife of the Northwest Territories. She has over 40 years of clinical, educational, and administrative experience in healthcare in institutional, community, and regional settings. It's important to note that both Dr. Baker and Ms. Lewis have worked extensively with CHSRF in our work on healthcare improvement and transformation in a variety of ways, and for that, we're very grateful. We're also very pleased to have them on the call today. In addition, we're also very pleased that there are more than 150 organizations registered for today's call, with representation across the country. Today's call begins with a brief presentation from each of our speakers, and then we'll then open the line for a question and answer period, where our facilitator, Maria Judd, who is Director of Strategic Initiatives here at CHSRF, will take questions from you, the audience. Those questions will come both over the Internet and by phone, and instructions for asking the questions will be given at that time. It's now my pleasure to hand things over to Dr. Baker.
Thanks very much, Stephen. It's great to be with you, and I'm looking forward to our discussion today. So I'm going to talk a little bit about this broader issue of healthcare transformation and lessons from Canada, and it creates, I think, a context to think more about a variety of issues, including the issues that Kay is going to talk about from her own experience. As you said, Stephen, this issue about financial investment and quality is an important one right now. We're heading into a period where we know resources are going to be constrained, but we're going to have to improve performance. And in the last decade, we've seen an enormous investment in Canadian healthcare, efforts to improve quality, reduce inefficiencies, and make the system better for the entire population. But the results have been only modest at best. And even in the areas where we've invested a lot of resources, wait times in particular, or primary care redesign, those results tend to really vary even within provinces from site to site. And so the question is, what do we do now, particularly as we know additional resources are going to be hard to find? What kinds of strategies can we use to move the results on more quickly and get more for the investments that we're trying to make? I want to point you to two resources. The first one is work by Jean-Louis and some colleagues in a report that's on the CHSRF website, which I think is a great overview of these questions. And the second report here is the one that I'm going to talk about today that Jean-Louis Denis and I have done based on a variety of sources, but in particular working on some research that I was involved in several years ago in a project commissioned by the Ontario Ministry of Health that led to the publication of a book of cases on high-performing healthcare systems, quality by design. So the basic strategy in that book that's reflected as well in the report that Jean-Louis and I did was not to focus on national performance, although we know that the policies and strategies at a national level have an important contextual influence on what happens. And the provincial strategies as well are important in healthcare, but really to focus down on regional systems because even in countries that are doing well overall, there's enormous variation in the ability of regions to execute on the local initiatives and to make change happen. So we're really focused on understanding what can we learn about local systems that provide services to a defined system. And the three systems we look at in our report are Intermountain Healthcare, which serves 1 million people in the states of Utah and Idaho in the United States, Jönköping County Council, which serves 340,000 people in southwest Sweden, and then a system that's just emerged as kind of an interesting model, the South Central Foundation, which serves 50-some-odd thousand Native Alaskans in the state of Alaska in the U.S. And as I note here, we did in-depth studies of the first two of those systems in 2006 and 2007 for our book, and we've been pursuing additional information about those. And in addition to that, looking at the experience of the South Central Foundation. And one of the advantages we've had in looking at this is that there have been a considerable interest from Saskatchewan in the South Central experience, and they have now sent 2 large groups to visit with people at the South Central Foundation. So we interviewed those people, we looked at existing documents, and we tried to identify the critical elements in their success. Let me say a little bit more about these systems, although I'm really only going to touch on the surface, so I urge you, if you're interested in any of these, to look at the reports that I mentioned earlier. Jönköping really emerged about 10 years ago as one of the participants in the Pursuing Perfection project that the IHI ran with money from the Robert Wood Johnson Foundation. And they were the star in Pursuing Perfection. So we took some of the best systems in North America, put a number of European systems in, and Jönköping consistently showed higher results and achievement in pursuing perfection. And there's a number of reasons for that. I think prime among them is the really consistent and focused leadership in the system that bridges the administrative and clinical systems. And they've had an enormous capability building exercise, which I think is really important. So leadership sets direction, but in order to execute, you need staff who have the skills and who can move the game forward, achieving clinical results and effectiveness. And then the other interesting story about Jönköping is the Esther project. As they did their redesign work, they discovered, as many of us have, that people are reluctant to change often because they see their role in isolation from the roles of others in the systems they work in. And the Esther project refocused people on care for a made-up patient, an older woman with chronic disease living in her home. And the question asked was, so what is the best thing to do for Esther? The second of these systems is Intermountain, which is recognized as being perhaps the most or the best system around the use of electronic information technology in the world. But the value of that technology really came to the fore in its connection with their quality improvement efforts and the work of Brent James, the leader in that system, who infused the ideas of Deming and modern quality improvement into the work in Intermountain. They also have had the advantage of creating a comprehensive leadership training course. You cannot become a leader in Intermountain unless you do their advanced training program. And they've restructured their system to really focus on the critical issues from a clinical perspective and made clinical leadership responsible for results using the information available to drive improvement. South Central is also an interesting example. They moved in about a decade ago in a transition from being part of the U.S. Indian Health Service, a highly bureaucratic and not very effective service in South Alaska, to being an independent, customer-focused organization that redesigned their care around primary care and with a clear understanding of the values and the vision to serve the Native Alaskan population, who they saw as their customer owners. That's the term that they use. And as they've moved forward, they've been very careful about selecting people who fit into their system at all levels and to train them and bring them up to speed and really focus on redesigning the system to serve those needs. So that's a very quick and obviously inadequate view of those three systems, but I want to focus now on 10 elements that we see as important in the work of these systems, and I think sort of might be a useful way for, as people think about the transformations that they're engaged in, to consider as well. The first of these, which I mentioned in respect to Jönköping, but it's true of Intermountain and South Central as well, is this notion that quality and system improvement is the core strategy, not one of 8 or 10 things that people want to do, but the way in which we define the mission and objectives of the system. And to do that, one has to build quality improvement skills and knowledge among the staff to give all of the staff at least basic knowledge and give some of the staff advanced knowledge so they can work in cross-function teams to understand the issues and identify the improvements that are necessary. And these systems, all of them, are built around robust primary care. So the focus is on providing care in the interface with the patient on an ongoing basis and not waiting for people to show up in acute care. And I think one of the interesting aspects about this is this notion that's emerging in many settings right now about engaging patients, not only in individual care decisions, where clinicians and patients make decisions, informed decisions about what's best, but in the design of the system itself. And we saw that at Jönköping. We see it to some extent as well in South Central and Intermountain in the work that they're doing, bringing the patient into the front of the room instead of leaving them to hear the results of the changes that we were proposing. And, of course, you can't do that except if you're in a situation where there's strong professional cultures that support interprofessional teamwork, continuous improvement, and the engagement of patients. So a few more items here. Clearly, we're focused a lot on chronic care these days, and Kay will talk about some of their initiatives. And I think as soon as you do that, then the focus has to be on thinking about systems of care, not individual sites of care, and creating more effective and seamless transitions between those sites of care where information goes with the patient and isn't have to be recovered anew every time the patient sees a provider. Information is a platform for making change, and many would hope that we will quickly get to an electronic health system. I think the reality is that this is going to remain a fairly slow process in this country for many different organizations. So at this point, we have to look at information from any source, guided by the issues that we're looking at, but integrated into the decisions about how well are we doing now and where do we want to improve. And related to that is this notion about taking the quality improvement projects that we see everywhere and now moving them to scale. How can we learn from individual unit projects and now do this not just for a unit, but for a system? So what methods do we need to test and scale up? This was a huge part of what we saw in Intermountain and Jönköping as they learned how to take individual ideas and move them across their systems. Now, all of this requires leadership at all levels, at the front line, at the middle of the organization, at the senior level, that has a common view of what they're trying to accomplish and a common language that they use to describe their priorities and their approaches. And leadership also has another duty, that is to protect people as they work on these problems. We're into a very turbulent period right now, and it's going to be very easy to be distracted. So the role of leaders is to focus on helping the systems forward and buffering those on the front line from some of these immediate pressures that they're going to be facing. Now, that's a lot to digest. I recognize that. So let me just say a little bit about those 10 elements and then reflect on what it means for Canada. First of all, none of this is quick activity. All these systems have worked for more than a decade, and Intermountain probably close to 2 decades now on these transformation strategies. It's slow and steady work. There are no quick returns. And these elements are seen in various priorities in these different systems, but I think we see all of these elements in the different ones. And the answers for us as we look for the strategies that are going to work in Canada are not simply to say we have to do what Intermountain did or we have to do what Jönköping did. Well, we have to create our own strategy based on the knowledge of our own challenges and these kinds of strategic elements necessary to move forward. And in support of that, let me just offer a few ideas. First of all, I'm a big proponent and big fan of the work that's going on in a number of provinces now, which have quality councils, which are helping the system identify priorities and to move improvement forward. I think we should be investing more in those kinds of activities. And we should also be investing in local capacity for improvement through training and leadership development. And that particularly includes physician leadership development. And I really fear that in this country we focus more on training individuals than we do about training systems of leaders that are going to help serve larger and long-term goals. We need to focus to figure out where we want to work on this because we do have limited resources for improvement. So the role of leaders is to help create a conversation where we identify the priority areas and then put our investments in that area. To gather the information we need, recognizing, of course, that the systems are not perfect. They're not the ones that we might want to work with in the future. And then lastly, this issue of patient engagement. I think bringing patients into the conversation is a challenging activity, but we've seen in work that CHSRF is sponsoring right now that it helps to change the conversation and creates a new dynamic for getting people to commit to improving care. So what does this take? It takes leadership, as I said, at all levels. We need to move forward with this conversation and start now. There is no perfect time to do this, so we really have to start while we have some resources and energy to make the improvements that we have to make. So that's a very quick view. I look forward to your questions, and I'm going to turn this over to Kay.
Thank you very much, Dr. Baker. Certainly it's my pleasure to join you this morning, and I look forward to your discussion as well. I'd like to share with you today some of the information on an exciting project that we've had here in the Northwest Territories on chronic disease management. In partnership with the Canadian Health Services Research Foundation, our Department of Health and Health Authorities, we developed and implemented a series of 4 health transformation project workshops. The workshops were aimed at strengthening capacity to use evidence, and in particular within our local context, as well implement sustainable and efficient health system decisions, processes, and policies. And overall, our deliverable was that we would have a chronic disease management service delivery model to build upon. You might ask, what was the driver? Well, it's probably no different than elsewhere. We have huge chronic disease populations that are aging and growing in number, impacting sustainability. And I will say that certainly diabetes, obesity, and mental health are problems that are growing within our system. The assessment and design of these workshops, we selected 3 conditions: mental health, diabetes, and renal care, mainly because these were high volume, high risk, and high cost programs that we felt we had certain challenges in sustainability. As we move forward, that we had those 3 groups, but we also added a health systems group added to address barriers. And this was mainly the leaders in the system, and it became evident that we needed to look at it on the broader context of the system and how we would remove various barriers and influence the structure. We used a tracer methodology to map our processes, and we had 40 staff, including healthcare providers, policymakers, and health system managers. This was particularly important that we had all players at the table, and I have to say it's the first time for me that when we started to address a problem, we had all levels of decision makers and providers in the same room, starting from the same page to create a solution as we move forward, and that was quite exciting. We held 4 workshops, and they were from December 2010 until June of 2011, and each workshop had a theme. The first one was on problem identification, and that may seem very simple, but I have to tell you that we struggled with it, and at the end of the day, we learned a lot from that process. Number one is that it's not always the problem that we think it is, and as well, do we really have supporting evidence or data to identify that that truly is the problem? So lots of lessons learned from that process. The next one was literature review and best practice, and we did look at the South Central Foundation. We have a significant Aboriginal population as they do there, and we are also remote in geography, so a lot of comparables and certainly some very good learnings from that we could incorporate into our thinking. It was really at this point in time trying to emphasize the importance at looking at what the literature can tell us and what best practice is out there. We then selected some solutions from what we learned from both the review within our own context and the literature, and then identified pilot and change management strategies. So that's the stage where we're at now in terms of going forward. So what did we learn from this? The first process of mapping the clinical processes and the dialogue that happened in that interchange from all levels of the systems created a very good understanding of the system issues. It also created a much improved communication among the various players, whether it be frontline service delivery, but realizing the importance that all of our roles had to play if we were going to address the issues effectively. The other thing is that even in a small jurisdiction like this, we realized we had pockets of excellence and very good practice that we really weren't aware of and was not shared. So certainly there's lots that we had that we could build upon that we already had working for us. The other was that what we perceived as the real problems were sometimes more symptoms than the system root causes. So we started to see chronic disease problems not just from the siloed disease perspective, but really from an overall organizational perspective. And interesting, if you look at these, what you might think is fairly distinct diseases in mental health, disease, and renal, and diabetes and renal care, we actually came out with very, very similar problems from all of that, the groups. One of the other things identified in the evaluation was the importance of senior leadership support and stakeholder engagement so that we could move this project forward. We obviously recognize the challenges, and that support is very important. The importance of using evidence-based information, that was certainly something that came out in our evaluation, and as well the ability to adapt the evidence to our local decision-making. And I think the other thing is that we realized that although we thought we didn't have a lot of data, that we had more than perhaps we were using, and had a much better appreciation of how to use that in supporting our decision making. And certainly as we go forward, that's something that will be upfront built into our processes much better, not only from indicators, but looking at how we can extract data from even the systems that we have. The process is transferable to other projects. As we mentioned earlier, it certainly was not just about those three entities. It was about building capacity, and as a system, can we really then transfer this across the system? And I think actually that we can. And great excitement around that, obviously some challenges, but there was very good learnings on getting a solid core of people, 40 plus, that now have these skills and have had this experience. So what was identified out of the groups work that needed to be addressed? One of the things was program standards for chronic care. We realized how different practices we were, even though that, as I say, in a small jurisdiction, but we really needed to have standard protocols and care approach based on best practice. Communication and collaboration within case management. In many ways, we're doing some of this, but there is real opportunities to improve that and as well involve the patient as part of that whole process, and that we have opportunities to look at our clinic processes and use full scope of practice in areas like advanced access to better improve our case management. The other thing is, who are we serving and what do we know about this population, and how can we track whether we're effective or not? There's the need to have patient databases and registry, and to look at our access and how we can then look at our wait lists and management of that particular population. Dr. Baker's already talked about the theme of patient engagement and self-management, and I think for many, we talk about patient-centered, but when we looked at the NUCA model in Alaska, it stretched our thinking beyond what perhaps our original comfort level, and now the challenge is to how we integrate that into our care. The other was certainly developing competencies and minimum standards service levels, because at the end of the day, you want to have competency across the system. So this slide on key elements of solutions were many of the things that we found as we reviewed the literature and concepts that we need to think about. We not necessarily addressed all of those in our pilot projects, and some certainly will be there as we go forward, but I think they certainly help to change our thinking and to look about best practice and how we can reorganize our system delivery model that these are taken full advantage of. Transdisciplinary teams, again, that we're looking across all of our care providers and how we can work together in developing consistency but continuity of care. Parallel processing, that when people come into the system that we're taking advantage of that and trying to be as efficient as possible, picking up other diagnostic tests and screening that need to be done. Case management we've talked about, and clinical pathways and the standardization that's there. Service agreements, so we know the levels of service. If we have partnerships, what we're doing with them. And again, the concept of rostering and knowing the population of who you're serving. Advanced access for primary care, that's certainly one that we're very excited about. In fact, just a couple of hours ago, we had a presentation on this and looking at how we can change our scheduling processes to the advanced access, the third next appointment, and increase efficiencies that are there. So challenging us to look just beyond this project into all of our organization and how we can do better with providing more consistent and better access. Non-physician providers, again, looking at the role that they play, and particularly when we have small communities and quite remote, we often rely on people within the community to provide support, and we need to ensure that we support them appropriately and utilize them effectively because they often have a lot of cultural knowledge that we really need. And, of course, how can we use more effectively telehealth and that expertise to share across, particularly in the large geography that we're talking about here. In terms of leadership, as I mentioned earlier, the dialogue between all the levels that were involved in the workshops became quite interesting, and I think it is important for leadership to listen to the frontline folks and the issues that they're having, and at the end of the day, we bring solutions that we can make work as a team together. The cultural competency, and we're certainly looking at teams and how we can, as a team, create that culture of working together, and again, the skills and invest in our leadership. And Dr. Baker did refer to this, and I think it's very true. If we expect things to change, we have to provide the supports and change our workforce and how they perceive their engagement in the system. Performance measurement, again, as we looked at our system and the data that we have, we do need to see if we're making a difference and have measurements that can help us do that. The supporting for self-management. As we looked at our system, we looked at what strategies we can engage people, and particularly in chronic disease. I think this is an area that we have a lot of room to improve on. But even beginning on having the dialogue on how we can improve, but also starting to document how we do. Decision support tools are critical, and clinical practice guidelines, but as well we're introducing the EMR, and we're seeing the real opportunities that are there to not only increase communication, but extract information and data to help us ensure that we're complying to clinical practice guidelines. And then, of course, patient registry. Excuse me here for a moment. Probably went one slide ahead here too far. So the challenges that we saw, well, the whole idea of using evidence and tools and problem solving and interdisciplinary collaboration, we've been talking about it for years, but in reality, are we really using it every day? And certainly some of the comments that come out from our evaluation was that for frontline folks and everybody across the system, how important this is. And often we jump to solutions without really identifying clearly what the problem is and going to the research and looking at the lessons that are out there before we go too far down a path. The integration of systems thinking into the everyday work. There was a lot of the dialogue from the varied players that were at the table of looking at it from different perspectives, and that certainly is a challenge to maintain that, but we learned how important it was and how much we learned from each other. As we go forward, sustaining the capacity developed in the system, we are a system that has frequent turnover, and when you have changes at all levels, in particular leadership, and when you have key peoples that have that passion and desire to move things forward, what happens when they move on? And that's where we need to embed this right into the culture of our organizations and make sure that it is sustainable. And I can say that at this point in time, as a result of these workshops, chronic disease management and the approach that we've taken is now part of the strategic plan for the government and embedded certainly in our work plans as we move forward. Expanding to other projects and sustaining that momentum, well, it sort of builds on that. There absolutely is a transferability of the information that we've learned from this, and now we have 40-plus people who have been exposed to this and can speak that language and start to share it, the enthusiasm. I have to say, when we started, there was lots of challenges. I'm not sure that people really understood what we were trying to do, and it was tough sledding to get them at the table and to engage in a challenging process. But once they went through it, they then saw the value retrospectively of what we can do. That will remain a challenge until that becomes strongly embedded. The organizational capacity for change, again, it talks about that you need that champions at every level of the organization, and you also need the investment of the resources to ensure that change moves forward, and the barriers that Dr. Baker talked about need to be addressed. Technology is certainly going to be a tool that will help us here, but we need to optimize that, and we also need to change the system in order to make the best use of that. And certainly decision support tools and the electronic medical record will be of particular value in chronic disease management. At the end of the day, what are the concerns? Well, I have to say that the expertise in facilitating the processes from the faculty at Canadian Health Services Research Foundation was invaluable. And you then ask, well, can we do this on our own? I guess I would say I believe we can, but that was certainly a very positive opportunity for us to have their support and to get this level of engagement and knowledge into the organization, and now it's up to us to take it on and move forward. So some of the themes that, and some of these are related to what Dr. Baker talked about, is the strategic realignment, and as we look at that, we've tried to focus on quality and make that a driver within the organizations. The organizations truly are the engine for delivery and change, so we very much have to have them on board. The professional cultures that are beginning to think and engage in decision-making, both using evidence, but case management and all of the team approach to this, creating and enabling an environment, and well, that's that leadership that we talked about earlier. And patient engagement, that certainly is a theme that's coming forward, and we will be challenged to change some of our previous more thinking of patriarchal and that we do for rather than do with, and truly utilize the expertise and engagement of the patient. And, of course, at the end, our objective was evidence-informed policy and decision-making. So those are themes that I think can be part of any project and are critical to put up on your bulletin board and say, we need to be thinking about this. So the next steps are implementation of these chronic disease management pilots that we've developed. And then, of course, as we know, it's not always the value of the pilot itself, but it's the change management that supports that is critical. So we're looking at strategies to move that forward, and we've got upcoming workshops to move it forward. there are many challenges associated with health system improvement because we're trying to, at the same time as deliver care, improve care. And so it's important that we provide supports for that and don't lose sight of it as we're so busy doing our regular business. It also needs to go forward to be a system-wide plan. It is there now and into the strategic plans, and not just for these three disease entities, but as a system-wide structure. And, of course, at the end of the day, we will have lots of lessons to learn. So I certainly would like to thank you for your attention this morning and look forward to your questions. Thank you.
Thank you very much, Ross and Kay, for your really interesting presentations. I'd just like to remind all our participants that you can download today's slides by clicking on the download presentation icon on the bottom left of your screen. I'm Maria Judd. I'm the Director of Strategic Initiatives at CHSRF, and I'm pleased now to take questions from you, our audience. There are two ways you can pose your questions today. The first is by using your computer electronically, and the second is by phone. Both English and French participants are invited to submit their questions electronically using the question box, which is located at the bottom left of your computer screen. For English participants who are not connected via computer, you can pose your questions verbally by pressing *1 on your touch-tone phone. When you're asking a question, we would ask that you would please identify who you are, who the question is addressed to, and just to pose one question at a time. Our first question comes from Alberta Health Services, and she poses the question, I think it would be great to hear from both of our speakers. How do you define transdisciplinary?
Kay, you want to start?
Sure, I can start on it. We've got many ways of saying multidisciplinary, interdisciplinary, and all of that language, and the definitions may vary in how we perceive it. I think as we've found in the literature here, it was using the term transdisciplinary in that it was across the systems and using all of our disciplines effectively. How it really differs from what we normally, I think it's the continuity that is really important there and the sharing of information.
Yeah, I think that's right. I mean, I think that there's a couple of critical issues here. One is to make sure that people who have different clinical backgrounds and skills are able to contribute to shared decision-making between the staff and the patient around what's best. And the second piece is this idea that Kay talked about, which we certainly see very emphatically at South Central, which is this notion about working to full scopes of practice. And we know in many places, people get extensive training and then they end up using really small parts of their training because they're not allowed to do some things in the context in which they work. And I think if we're going to have effective care, especially on difficult issues like chronic care, chronic disease management, then we have to allow people to work to full scopes. And that's, in the end, I think more rewarding for everybody, but it's not the way some people have worked, and so it's difficult for them to get into that mode of thinking.
Okay, thank you. Our next question comes from Ontario. It's picking up on, you mentioned, Kay, the challenges of getting everyone at the table at the beginning of the project. Do you have any insights or reflections on what made that successful to share?
Well, that was trying to get buy-in from the CEOs and other health authorities, and as well as the department, to allow people to participate. I think one of the other challenges that we had was trying to ensure that we had enough notice ahead of time to clear clinical schedules and allow people to come for the time. There were 2-day workshops. Our physicians are salaried, so that really made it easier from that perspective, but still a challenge to take 2 days out of your clinical work. In the end, it was absolutely imperative, I think, to have all of those players at the table, but it was from the very beginning trying to get buy-in that if we were going to make these changes, we needed to have people at the table to have their input so that they wouldn't be the resistors later on, but also could have the very important expertise that they bring to the table. I have to say that in selecting the various players, we chose carefully not always people that might be the obvious ones for these disease entities, but also tried to look at where some the bright stars out there that as future leaders and champions that we wanted to involve and make sure that they were part of this process and had the opportunity to learn.
Thanks very much, Kay. Just like to remind everyone that you can pose questions either using the computers or the box on the bottom left-hand part of your screen or by pressing *1 on your touch-tone phone. Our next question is for Ross. It comes from New Brunswick, and the question is, have there been high-performing systems identified within Canada?
So in our book, we have 2 case studies of Canadian systems. One is the Trillium Health Center in Mississauga, which is a 2-site acute care facility, and the second is the former Calgary Health Region, which we looked at in 2006 before the changes in Alberta, which removed the regions. And both of those have similar exemplary characteristics that we saw in the international systems. We had not originally intended to include those, but we realized very early on in the study that it was important to seek Canadian examples as well, both to show that these elements can exist in our systems despite differences in our structures and payment and so forth, and to provide a sort of easy-to-access source of comparison for people who are looking to achieve similar goals in their own systems.
Thanks, Ross. Our next question is for Kay. It comes from government in BC, and the question is and if so, how were researchers involved in the workshop process?
Researchers were involved in the last workshop that was there, and I have to say you're raising a very good point because I think we recognize that we needed to have them going forth in the pilot. So we did have an evaluation team come and challenge us and certainly help us to move forward with the evaluation component for the pilot stages. But we were late, and I think probably that was an oversight.
And the next question is similar, but I'm wondering, Kay, how and if patients were involved in the 4 workshops.
Oh, that's an interesting question. Initially, they were not involved, and then we started to think about how we could involve them. The last workshop, we had a presentation on patient engagement to help us give some thought how they could be involved, because I think it became certainly a desire from the group that we needed to think about this and how we could involve them successfully. So we had the presentation on that, and now it's the challenge of how we involve them in the pilots going forward. But again, up front, no, and whether it was oversight or we just didn't have the courage, I'm not sure, but they were not involved.
And the next question is from BC again, and building on the topic of patient engagement, the question comes, you mentioned patient-centered and going beyond that, indicating customer ownership. What are your thoughts on engaging patients in the success of system transformation building forwards from your pilot?
I think we really do need to take this very seriously, and that is going to require quite a cultural change in many of our providers. So we started, as I say, with the education system, and now we have to not only, there's a desire to do that, but how do you then effectively do it as part of the system? And that's what we're working on as the pilot. I don't have all the answers. All I know is that they have a lot of value to add, and that's starting to come through, and the groups are starting to really want to do this and have the desire. It's how we can best do this in an effective manner.
Thanks, Ken. I think that's an important point, that nobody has all the answers, but there's a lot of important work going on across the country in pilot projects, and that's certainly a role CHSRF hopes to bring to that in amplifying and evaluating some of those efforts and sharing some of the lessons learned and strategies and spreading those across the country. And I know you're both involved in supporting that, and thank you. Our next question comes from Health Canada, and the question is, first a comment and then a question. Much of the focus of the presentation is on systems. Do you feel that there's a good understanding on systems management, complex adaptive management, or is this a barrier amongst leaders in these kind of initiatives? And I think it would be great to hear from both Kay and Ross.
I think many healthcare leaders recognize that they're working in complex adaptive systems because of the many issues and the many sort of stakeholders that they're involved in. And healthcare leaders who try to get things done by operating as if it's a mechanical system that they can sort of create direction and expect people to follow, I think are not ones that stay in the system very long because they have a lot of frustrations. So I think it's the experienced leaders quickly see that they need to create an environment where they raise the energy level and commitment of the professionals and other staff who work with them so that they're moving forward together. And that's an important, I think, challenge, but it's one that is necessary if you're going to do any effective work in improving systems in healthcare.
And I would just comment that certainly I agree with Dr. Baker. I think there is systems thinking. I think probably the challenge is that it is a very complex system, and sometimes we can't adapt and change as quickly to get the kind of results that allow the momentum to keep us going forward. But I think for the most part, leaders understand that we need to utilize systems thinking, and there's many parts that are extremely important to the whole piece. It's just the making it all work together.
Thank you. Our next question comes from Saskatchewan government to both speakers. Certain elements of best practices make some stakeholder groups uncomfortable. Given this, reforms are often implemented in a piecemeal fashion and are sometimes missing select elements of the best practice literature. So the question is, in what fashion have you seen systems overcome this challenge?
That's a really good question, and it's a challenging question that I think many people are grappling with. So we often do changes, and we identify a number of changes, and then we put them through the filter of, which of these are acceptable to the various players who have to be involved in that. And one of the reasons why involving patients is such a game changer is that conversation is very hard to sustain when you have a group of patients in the room. Because their perspective is unclouded by those kinds of issues. So I really, changing the framing of those questions from a question about negotiations with professional groups to a question of how do we now design a system that's going to serve the needs of the population, with the resources that we have most effectively. I think that's the critical way that we have to move forward on these issues.
I think the other thing is it's certainly as practitioners, many people have their own way of doing things and they are resistant to change. What I've always found is that when you present the literature as to why you're doing that and you put it in the context of patient care and that we're really trying to make changes, and at the end of the day we don't change things, then we're not going to get a different outcome. But I think as well, even if the patient isn't in the room, if you try to put that focus on what we're trying to do, it starts to be a different dialogue using certainly the literature as to why you're doing it, and really what's really important here are the peers. And often I find that the outliers eventually will come on board if you've got some champions that will really move it forward. It's challenging, but I think it's doable.
Yeah, and just to sort of follow on from that, I think one of the interesting insights from Intermountain is, with their electronic system, they're able to capture details on clinical practice and the decisions that physicians and others make about the choice of treatments and drugs and so forth. And they have a very strong decision support system, which they have developed and continue to develop over time. But the message they give to the clinicians in the system is this is meant to be a help to you, not to direct you what to do. And if it's your clinical decision that you want to do something different than what we're recommending in the decision support system, we would urge you to do this. But if you do that, then you have to write a note as to why you decided to take another route as opposed to the one that was suggested in the decision support system. And I think that has two important values to it. First of all, it recognizes that all these systems are incomplete and that complex patients come forward who probably should be treated in different ways, and that we can learn from those kind of clinical insights. But it also sort of, gives people pause because now it requires them to go to a different level of asserting their knowledge than simply, I know what I'm doing, so let me do it. And I think, it's respectful of professional decision making, but it also requires people to deal with it on the level of evidence and not on the level of personal preference.
To give an example of something we've done here recently, we pulled out of our electronic medical record all of the data on what were our practice decisions and what did they look like. And what we saw was a wide variety. And just shared that information with the practitioners and said, well, why should it be this different? And I think they were quite surprised to see it. And that alone was information. Now they're starting to think, well, what should be our consensus here as a group, how we move forward? And as Dr. Baker said, there's always exceptions to that. But sharing that information automatically started them to think of the need for them to work closer and look at what the standard should be and how they could start to be more compliant.
The next question is from Ontario, and it's to Kay. If you could please elaborate on what your group found the value of pilot improvement project was.
Well, we haven't implemented the pilots as yet. Certainly what I see as the value that's here is that we can talk about all of our problems and put all of these great plans in place, but if we don't make any difference, then I'm not sure that we've succeeded. So the pilot was to take out at least very key elements of this and to implement them and evaluate and learn from them before we implement them broader across the organization. There's certainly always pros and cons to pilots. I think one is that it allows us to focus our energy and hopefully have it successful. That's there. The other thing is just the change management. To change the whole system at one time is a little bit daunting. So we're trying to do it. Take key pilots and test those. That at the end of the day, we've got some learnings before we do it system wide.
I think that's the right approach. I mean, I think, as Kay said, you see good ideas that have worked in other settings, but clearly they need to be looked at in light of the current practices and the environment in which you want to do it. And so the right strategy is to test those ideas in a local way and then figure out how to scale them up.
Great, thank you. Our last question comes from Ontario, and it's for Ross. On the slide, some steps forward for Canada, you highlight expanding and enhancing the roles of quality councils. What would be your vision for this?
So my vision about this is really influenced by my experience in Saskatchewan, where I think the Quality Council has been a major lever for helping the system as a whole. And the key here is that the Quality Council accelerates local efforts. It doesn't replace local efforts, but it works in collaboration with the regions and the organizations across the province to identify critical issues, to build skills, and then to implement and test local changes. And I think that has been a very successful movement in Saskatchewan. And those of you who have been following what's happening there, it's a very exciting time and a sort of system-wide engagement in new initiatives and alignment from the minister and deputy minister right down through the regions and front lines of the organizations. And nobody's perfect, but the energy in Saskatchewan and the achievements so far, I think, have put them in a really good position to deal with the challenges we're going to see in the next 5 to 10 years in our system. And I see that as a model that could be replicated in other parts of Canada, and clearly There's some provinces, BC, Ontario, Alberta, which already have many of those elements in place. And the Ontario Health Quality Council is now Health Quality Ontario, with a broader mandate and an opportunity to really influence the system in a much more profound way than they have to date. So I think this is an important resource that we need to invest in the system, because, smart clinicians understand the care of patients one by one, and they need now work with people who have the improvement skills, the improvement knowledge, to take good ideas, to test them in practice, and then to move them to large-scale implementation. And those resources need to come from somewhere, and the somewhere is both the local delivery organization aided by a group like the Health Quality Council.
Thank you. I'd like to thank both Ross and Kay for their excellent presentations, and to you, our listeners who listened, and also those who submitted thoughtful questions and facilitated the discussion we've just had. We hope you join us for our next session, CHSRF On Call, in just 2 weeks on November 10th, and you can find more information about that session and subsequent ones at www.chsrf.ca/on-call. We'd also like to encourage folks to sign up for our electronic newsletter at CHSRF so you can stay up to date on other CHSRF activities. We'd greatly appreciate your feedback on today's call, and we will be emailing a survey out to you in the next 24 hours. I'm Maria Judd, and on behalf of CHSRF, I'd like to extend a sincere thank you, especially to our speakers, Ross and Kay, and to all of you for your participation today. This concludes today's CHSRF On Call, and we wish you enjoy the rest of your day. Take care.